Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice typical example of a spindle cell lipoma. So this is a case of a 68-year-old male patient who presented with upper back mass of several years duration. And this case is actually courtesy of Dr. Iman Hijazi, who shared the case with me. So as you can see here from the low power magnification, there is this lipomatous component. So you start thinking about lipomatous tumors, including lipomas or well-differentiated liposarcoma or atypical lipomatous tumor. In addition to the lipomatous component, we have this pink component in between, which is slightly cellular. And just zooming in into one of those areas in which is rich in the lipomatous component, we have variably sized lipocytes. Most of them are univacuolar. They only contain one lipomatous vacuole with eccentric nucleus, and in other areas you don't even see the nucleus. Now there are some spindle cells in between, but the predominant component here is the lipomatous component. And moving on from one field to the other, you start to see again those large lipocytes, scattered mast cells, which are important clue to the diagnosis of a spindle cell lipoma. And then we have some stellate cells or some spindle cells in between. Now, moving on more and more, you start to see less of the lipomatous component, more of the spindle cell and stellate component, and more of the collagen. Scattered mitotic figures can be seen every now and then, as well as a mild, really minimal degree of pleomorphism in the spindle cell component and in the stellate cell component. Now, in other areas, the field would only be composed of those stellate cells or spindle cell cells. And again, here a mast cell among this larger number of spindle cells, as well as some stellate cells, in the absence of any lipomatous component. In some areas, even this lipomatous appearance is completely absent. What you see is the spindle cells as well as the stellate cells, and then this very characteristic collagen, which is the ropy type of collagen, extremely important to render or support the diagnosis of a spindle cell lipoma. Again, other areas which are lipoma poor, fat poor areas, composed mostly of those spindle-shaped cells and the ropy collagen that is present in the background, as well as the mast cells. And again here, just to highlight beautifully the collagen, and the collagen, by the way, is refractile. So if you try to polarize the collagen, it would show also beautifully, and more of the different shapes and sizes of the collagen, the stellate cells, the spindle-shaped cells. And this actually very beautiful field summarizes the features that we usually would like to see in the typical case of a spindle cell lipoma. We have a lipomatous component, we have the spindle cell as well as the stellate component, we have the ropy collagen, and we have the mast cells. These are the four components that are usually typically present in spindle cell lipoma, albeit in varying proportions. So some tumors would be really rich in fat, others would be fat poor, with the predominance of the spindle cell component and the ropy collagen. And here comes the difficulty in establishing the diagnosis. Now, one important differential diagnosis that we have to think of is atypical lipomatous tumor, for which the MDM2 is usually can show some focal staining in nuclear staining. In this case, it was completely negative. These are the mast cells showing the non-specific cytoplasmic staining with MDM2. This is completely negative for a nuclear staining, and this is some of the negative shadow of the ropy collagen. S100 can show some focal positivity, but what is really important, number 5 criteria, is positivity of the spindle cells for CD34, cytoplasmic positivity for CD34. So the final diagnosis in this typical case is spindle cell lipoma, and what I meant by typical is the age, the gender of the patient, as well as the location. Remember that these tumors are usually occur more commonly in the upper back. In particularly, they have superficial location. This particular case was really large. It was 25 centimeter in maximum dimension, and the cut surface was myxoid, which might make one wonder whether this is an atypical lipomatous tumor or a myxoid liposarcoma, for example, versus spindle cell lipoma. But these are typical gender, typical age, as well as typical location. Remember that spindle cell lipoma can be fat cell or rich or lipomatous component rich, but it also can be lipomatous component poor. The clue would then come from the clinical details, that we should always be sure to have an adequate clinical input as well as the location of the tumor. Remember that the 4 typical components of spindle cell lipoma are a lipomatous component. Sometimes even we can see some lipoblast. This does not rule out the diagnosis of spindle cell lipoma. In addition, we see the spindle cells, sometimes stellate cells as well, the ropy collagen, which can be refractile, as well as the mast cells. Remember that the spindle cell component can be positive for CD34, as this was the stain was in this case. And remember that spindle cell component is kind of related to another benign lipoma, which is the pleomorphic lipoma, in which we see florid cells present among the typical infiltrate or the typical morphological features that we encountered in this case. Now, I have in the caption a link to an open access article that describes a large number of spindle cell lipoma. I think they were 25 cases, showing the variation in the morphological spectrum that you might encounter in spindle cell lipoma. Once you are aware of the clinical as well, the typical clinical presentation, as well as the location, in addition to the morphologic variation, in particular the 4 components that I've just mentioned, in addition to the positivity with CD34, then the diagnosis can be rendered easily. I hope you find this tip useful in your daily practice. Thank you.